Good evening, teachers. I'll be presenting a case of white dot syndrome. So, multiple evanescent white dot syndrome is a rare ocular condition with an incidence of about 0.45 in 100,000. It is characterized by the sudden appearance of multiple small white lesions in the retinal area. MUDES primarily affects young to middle-aged women. It is often unilateral and associated with symptoms such as visual disturbances, blurred visions, or scotomas. So, in my case, a 22-year-old female presented to the OPD with multiple episodes of diminution of vision associated with pain, redness in the right eye since 3 months. There was no complaints of discharge, photophobia, flashes, double vision, and no previous history of ocular trauma or surgery. History of fatigue, however, was present. No history of joint pain, urinary complaints, or fever. She is nil systemic. Ocular examination. In right eye, the visual acuity was 660 with IOP by rebound tonometer, lid agnexa normal. Conjunctival congestion was seen with iris pigment dispersion on endothelium. 3+ cells and flare was seen in the anterior chamber, and posterior synechiae was seen from 9 to 10 clock hours. The left eye vision was 618 parts with rest of the anterior segment within normal limits with mild anterior chamber reaction. Fundus, the right eye media was clear with a hyperemic disc associated with disc edema and peripapillary edema. Small multiple choroidal lesions suggestive of choroiditis was seen. The left eye media was clear, hyperemic disc edema with peripapillary edema and a macular edema was seen. A macular OCT was done for this patient. Right eye showed mild choroidal elevation and the left eye showed pockets of subretinal fluid. B-scan was done which showed a normal choroidal thickness, and fundus fluorescein angiography revealed early hyperfluorescence. The exact etiology of multiple evanescent white dot syndrome remains uncertain. However, it is thought to involve a viral infection with some studies suggesting a potential link to herpes virus infections. Additionally, there may be an autoimmune component as well. However, in my case, the chest X-ray, serology, HPV viruses were all negative. Clinical examination and imaging resulted in a diagnosis of multiple evanescent white dot syndrome since it was the first episode. The patient was started on a regimen of systemic and topical steroids along with cycloplegics. She is currently symptomatically better and on regular follow-up. However, OCT still was suggestive of choroidal elevation. Differentiating MUDES from other retinal disorders is crucial, particularly from conditions like acute posterior multifocal placoid pigment epitheliopathy, since in this condition neurological manifestations are also seen and requires further neuroimaging. It is also important to differentiate it from multifocal choroiditis, as in such cases regular follow-up is mandatory as they can develop choroidal neovascularization. Imaging techniques such as OCT, fundus fluorescein angiography aid in the diagnosis. So take-home message is it is important to reassure the patient. We have started her on steroids as there was uveitis-like picture, and it is important to keep patient on regular follow-up.
Does the patient have anterior uveitis also?
No, sir. The picture, posterior synechiae was there, but AC reaction
so normally MUDES wouldn't have a anterior synechiae, no? So you wouldn't require steroids. Otherwise, MUDES is self-limiting. Generally, we do give steroids, but it's so you need to rethink the diagnosis if you're having anterior uveitis with MUDES.
Yes, sir.
So more evaluation required for this patient.
Currently, AC reaction is
so if it's still there, you really will have a synechiae and have anterior uveitis. So I think we need to
anterior uveitis is not there.
So you need to relook the diagnosis of MUDES. Thank you.
Thank you.
Thank you.